Hello, my name is Miranda Pickett, and this is my Unit 4 Case Connections video presentation. As you can see, I'm at work here. I'm on a 48-hour shift, so please excuse my messy hair and my no makeup. It is 10:21 here, so close to the end of the day of my first part of my 48, so it's been a little busy, a little tired, but here we go. So the cases that I'm going to be covering in this presentation are case number 1, which is a neonate metabolic disorder, and case number 3, which is a gout presentation in a 45-year-old male. Moving right along, I just wanted to give a quick review of case number 1. It's a newborn girl who presented normal at birth. However, in the first 24 hours, she developed lethargy, hypothermia, and apnea. The attending physician who is evaluating this patient believes that she's suffering from a metabolic disorder and is ordering a panel of labs. What this case is asking us initially is what's the best diagnostic tool to determine whether the patient is suffering from a urea cycle disorder or from a beta oxidation disorder. And it gives us 4 choices here, which are blood glucose, urinary acids, serum fatty acids, and plasma glutamine. It also tells us that the physician did order a full blood workup, and some of the results that came back was an initially elevated blood ammonia level at 314, which then became markedly elevated at 600. The urine orotic acid level was also elevated at 473, and the plasma citrulline level was actually normal, which is a very good indicator of what we have going on here. We'll talk about that later. The other question it's going to be asking us is, because of the orotic acid levels being elevated, it's asking us to list one urea cycle enzyme that's most likely deficient and one urea cycle enzyme that is least likely to be impaired. So we'll cover that, Sean, in just a few slides here. So to begin the actual discussion on case number 1, it's important that we find the right diagnostic tool to determine the disorder, because beta oxidation disorders and urea cycle disorders often present in very similar ways. So it's important that we find the right diagnostic tool. In my opinion, I think that the child is suffering from a urea cycle disorder, which the appropriate test will confirm. But I also wanted to make a special note here that urea cycle disorders can also be tested genetically through genetics testing in most cases. Moving on to the laboratory testing, like I said earlier, we have the options of blood glucose levels, serum fatty acid levels, plasma glutamine levels, and urinary acids. Starting with blood glucose, I want to rule out this lab because it doesn't give us enough information to differentiate between a urea cycle disorder and a beta oxidation disorder. However, it can be useful in later diagnosis once you figure out whether we are determining if it's beta oxidation disorder or if it's urea cycle disorder, because hypoglycemia can be a symptom in multiple disorders in either case. So once we figure that out, we can use the blood glucose level to further determine which disorder it is in the correct category. Again, ruling out blood glucose. With serum fatty acids, I'm also going to rule this out. It's a great detector for beta oxidation disorders, because with beta oxidation disorders, the body's not able to break down the fatty acids properly, so you get a buildup of fatty acids. Because of this, like I said, it'll be a great detector for beta oxidation, but it won't be a great detector for urea cycle disorders. Therefore, ruling this one out as well. Plasma glutamine, we're going to rule this one out as well because it's a transporter of ammonium. So it's not going to give us any information about urea cycle acids. It's only going to give us information about the level of ammonium that's being transported. Which leaves us with the correct answer, I believe, being urinary acids. This allows for the measurement of acids related to the urea cycle. Therefore, it would give us basically a determination of how the urea cycle is functioning in the newborn's body. And since beta oxidation disorders would not cause elevated urinary acid levels, it also allows us to rule that out. Moving on here. I believe that the newborn is suffering from an ornithine transcarbamylase deficiency or OTC deficiency. And this is because she's suffering from high ammonia, high urine orotate, as well as normal citrulline. And as I said earlier, that's really important in making this diagnosis. I believe that the ornithine carbamyl transferase is the most likely to be impaired because when this enzyme is impaired, it causes a it causes a buildup of urine orotate levels and also indicates normal citrulline levels, and I'll be able to explain that a little more in the next slide. I believe that the enzyme that is most likely to be is least likely to be impaired is the carbamyl phosphate synthetase 1 due to where it's at in the cycle of the urea cycle. And I'm going to go ahead and move on to the next slide so that I can show you a little more efficiently on which is least likely and most likely to be impaired. So as we can see through the urea cycle, we have 5 primary steps here to do with enzymes. Because we have a buildate of blood orotate and a normal amount of citrulline in the blood, this is why I believe step number 2 here with the ornithine transcarbamylase is most likely to be impaired, because here it's affecting our ability to create ornithine, and then not affecting our ability with citrulline. However, with the carbamyl phosphate synthetase 1, I don't think it's going to be impaired because it's occurring before the defect with the ornithine transcarbamylase. Because we have a defect with ornithine transcarbamylase here at step number 2 in the urea cycle, it's going to affect the rest of the steps here in the cycle because it's basically a reaction chain in and out of the mitochondria. You can see the reference down here for this picture, just for giving them proper accreditation for their work. That concludes case number 1, so we're going to move on to case number 3. And this is a 47-year-old man who's presenting with severe pain in his great right toe. He's unable to bear weight on his right foot, and this appears to be happening with no trauma. He reports that the pain started last night and is increasingly getting worse, which has brought him into the ER, I believe this would be. When the physician does the physical exam and does a laboratory finding, the patient's diagnosed with gout. In this case, we're going to be asked what's the best explanation for the presentation of gout in this individual, and it gives us 3 options here: the overproduction of purines, the decreased salvage of purines, or decreased urinary excretion of uric acid. And we're going to discuss all of these in detail in the next slide. But it's also asking us what additional information we might need to decide the root cause. Something else it's asking us is that the patient is telling us that he switched from diet soda to regular soda, which is asking us what impact it's going to be having on his presentation of gout, and we'll discuss that as well. So moving on to the discussion portion, I couldn't transfer the blood analysis results to the PowerPoint, so I'm just going to tell you what they are really quickly right here. So a normal uric acid levels through research are 250 to 750 milligrams over 24 hours, meaning that that's what the normal levels of secretion are through the urinary tract. The patient's is 215, making it below normal levels, which is interesting and will help us to talk about his presentation. Normal plasma urate levels are less than 7, and I apologize, I put the incorrect symbol there. But the patient's is 10.5, which makes his plasma urate levels elevated. Both of these things suggest a problem with the metabolism of purine in the patient's body. Now, through research, I found that technically both the overproduction of purines and the decreased urinary secretion of uric acid can contribute to the diagnosis of gout. However, in this assignment, we are asked to choose one. So I think that the correct answer here is the overproduction of purines. I think this is contributing the most to his presentation of gout. However, let me first talk about this. The patient is most likely suffering from a deficiency of the PRPP synthase, which is causing an overproduction of purines, which is then causing a buildup of the purines in his system. A secondary effect would be the decreased secretion of uric acid, which is usually caused from the decreased solubility of the purines. Once both of these things happen, urate crystals would be formed because there's such a high concentration in the blood. Urate crystals would be formed, and they would actually be transported to the patient's joints, which would cause pain, and obviously the presentation of what he's experiencing, which is the gout, and the pain in his right toe. Something important that I should mention is that the purine salvage pathway could be affected because PRPP is an element used in purine salvage, but I don't think that it's a major contributor to the actual presentation of the patient's symptoms and diagnosis of gout. So just to make myself clear, I believe that the correct answer here is the overproductions of purines, even though a decreased urine output could also be contributed to it, and that purine salvage would actually be affected by the process. Some additional information that we can gather is renal labs, because in a lot of cases renal function is declined, and it's actually a later symptom, but it can kind of give us an idea of where this patient is at with his disorder. And most often renal function is affected because there's some kind of renal tubular defect. And I put a article in my references about this, but I believe that renal function labs would be some important additional information to add to the patient's diagnosis. On this next slide, I added a picture that I found on a website with one of my references. I just think that it's a good kind of visual aspect of what the patient is going through. So as you can see here, it adds on to what I was saying earlier about both of them causing the hyperuricemia, the overproduction of purines, and the underexcretion of uric acids, causing hyperuricemia, which in turn can cause all of these things. The patient is mainly presenting right here with gout. However, as I was saying, we could also have a renal manifestation. Luckily, the patient isn't experiencing any cardiovascular events and obviously not mortality, but it's important to note that later down the line, this is really important and can cause death. The website that I got this picture from can be found here at the bottom of the slide here. Moving on with the dietary restrictions, the patient is drinking, I believe it's at 4 to 5 liters of soda a day, and that's a very large amount for anyone, but especially for someone in his condition, as soda contains fructose or high fructose corn syrup. Once fructose or high fructose corn syrup is ingested, it's actually broken down to form purines in the body, and then obviously the purines are then broken down to form uric acids. So we know with gout we're already having an overproduction of purines and an underexcretion of uric acids. So ingesting fructose or high fructose corn syrup is just adding to his problem, and it should definitely be something that he gets under control. Alright, that concludes my video presentation. My references for all this information can be found on my video presentation script that I'll also be providing. Thank you for listening, and I hope you have a wonderful day.